Welcome to the deep dive. We're your shortcut, really, helping you cut through all the noise out there and get straight to the core insights. In this world just awash with information, trying to really grasp complex topics, let alone build effective solutions, it can feel overwhelming. So we're here to be that curated guide. Today, we're taking a deep dive into something called intervention mapping. Now, if you're involved in program development, especially, say, in health education, this framework, well, it's designed to take a lot of the guesswork out. It helps you build programs that actually work.
Hmm.
Think of it like having a master blueprint for making an impact.
That's a great way to put it. Yeah.
Yeah.
Intervention mapping gives you this systematic step-by-step process. And it's for developing health education programs that are, really firmly rooted in solid theory and actual empirical evidence. It's all about translating what we know into concrete, actionable steps that hopefully make a real difference.
Right. And our mission here today is to unpack this framework. We want to understand where it came from, its purpose, and, how exactly it helps bridge that gap between a brilliant idea and actual real-world impact. And to guide us, we're mainly looking at the seminal 1998 paper by L.K. Bartholomew, Parcel, and Gerjo Kok, basically the foundational text for this whole approach. Okay, so let's unpack this then. What was the scene like in health education program planning before intervention mapping arrived? You mentioned a gap. It sounds a bit like people were, I don't know, trying to build something really complex with maybe a good idea, some materials, but no actual blueprint. What did that look like in practice?
You've really hit on something there. Imagine trying to assemble, say, some complicated IKEA furniture. You've got the picture, you've got the parts, but no step-by-step instructions. You have dedicated people, great intentions, sure, but also probably a lot of frustration, wasted effort. That was kind of the reality for many in health education planning. There were good models for needs assessment, figuring out the problem, and also for program evaluation, checking if it worked after the fact. But there was this huge, often just theoretical leap needed for the actual design and the implementation part. So practitioners, students, they were asking things like, okay, when exactly do I use theory in this process? Which theory should I even pick? And the big one, how do I get from this broad goal, like improve community health, down to the specific things participants need to do day to day? That lack of clear guidance was a real problem.
Okay, so intervention mapping comes in as the answer. It provides that missing blueprint, that recipe. I love the core metaphor they use in the source. It's analogous to geographic mapping. It enables the planner to discover relations, locate desired destinations, plan a route, and execute the plan. But what's interesting is you said it's not like a static roadmap, right? It's iterative.
Not at all static. Yeah, think of it more like agile software development, or maybe even like cooking. You don't just follow the recipe rigidly once and assume you're done. You taste, you adjust, you refine as you go based on what you're learning. That constant feedback loop, it's built right into intervention mapping. You're actually expected to cycle back, maybe refine step one based on what you discover in step three.
Ah, okay. So it allows for learning and adjustment.
Exactly. And another fundamental thing about its philosophy is this principle of self-determination. For individuals, for communities, it's not meant to be top-down. It really facilitates collaborative planning, bringing together people with different backgrounds, different expertise, and crucially, it always kicks off with a really thorough needs assessment. That's not just a quick check. It's the foundation. You lay that groundwork before you even start the main IM steps.
Right. You need to know where you are before you can map the route.
Precisely. You can't chart a course without knowing your starting point and your desired destination in detail.
Okay, stage set. Let's get into the heart of it then. These fundamental steps, how do they build on each other?
Right. So step one, creating matrices of proximal program objectives. This is foundational. It's where you move beyond vague hopes like improve health.
Yeah.
You get laser focus on who needs to do what specific action, and crucially, why aren't they doing it now? What's stopping them? The output here are these detailed tables, these matrices, that force you to connect concrete behaviors with their underlying drivers, the determinants.
Okay, let's clarify performance objectives. Because the source says, eat more fruits and vegetables isn't specific enough. What does a good one look like?
Yeah, it's too broad. A good performance objective breaks it down into observable actions. So for that fruit and vegetable example, maybe. Substitute fruits or vegetables for junk food snacks after school. That's specific, you can measure it. Or, thinking environmentally, the school cafeteria manager will increase the fruit and vegetable choices available in the school lunch menu each school day. Again, very specific, observable.
Got it. And then the determinants, what are those?
Determinants are the factors influencing that behavior. They can be personal things like knowledge, beliefs, skills, self-efficacy, Or they can be external social support, access, policies, physical environment. So in the cystic fibrosis program example, the CF program, they hypothesized determinants like behavioral capability, did people have the skills? Self-efficacy, did they believe they could do it? Reinforcement, outcome expectations. And it's also really important here to differentiate your target population if needed.
Differentiate how?
Well, in the CF program, they knew the needs of a young child with CF are very different from an adolescence. So they differentiated objectives and determinants based on developmental stage. They also made separate matrices for the patients themselves, their parents, and even the healthcare providers, because each group had different roles and needed different things.
Okay, so our map now has a very precise destination, the performance objectives, and we've identified the key terrain features, the determinants that influence getting there. What's next? How do we choose the actual route? The how. This sounds like step 2, selecting theory-based intervention methods and practical strategies.
Exactly, and the source makes a really useful distinction here between methods and strategies.
Oh.
Methods are the general techniques. They're derived from theory or empirical evidence, and they're known to influence those determinants we just talked about. Think of things like modeling, skill development, persuasive communication, community empowerment. These are broad approaches. Strategies, then, are the practical, concrete ways you actually deliver those methods. They're the specific activities, the tools, the materials you use.
Okay, so how do you get from a general method, like you said, modeling, to something tangible you can actually use in a program?
Good question. It involves brainstorming potential methods first.
Yeah.
Then you really dive into the research literature. You look for evidence, does this method actually work for influencing the specific determinant you're targeting? And critically, you look at the working parameters.
Working parameters.
Yeah, like under what conditions does this method work best? With which audience? Is modeling more effective via video or in person for this particular group? Then you translate that into practical strategies. The CF program example, again, is great here. They found adolescents with CF just weren't keen on group meetings. Understandable, right? So the method was modeling, showing them how others cope. But the strategy became delivering those role model stories via a news magazine print format. It made the method acceptable and relevant to that specific group. That's tailoring the strategy.
So the strategy is how you package the method for your specific audience and context. Makes sense.
Precisely. Which leads us nicely into step 3, designing and organizing a program. Now you're actually building the thing. You take those strategies and operationalize them. You design the actual program components, figure out the scope and sequence what comes first, how long does it last, and you choose your delivery channels. Is it face-to-face workshops, a website, newsletters? Maybe a mix.
So this is where you're creating the actual materials, the handouts, the videos, the website content.
Exactly. Designing scripts, storyboards, pamphlets, whatever it might be. And a really critical piece here is producing or choosing and pre-testing materials. The source really stresses this. Pre-test with new people from your target audience, not the folks on your development team.
Why not the team? They know it best, don't they?
They know it too well, potentially. They might overlook jargon, confusing instructions, or things that just don't resonate because they're so close to it. You need fresh eyes, unbiased feedback to make sure the materials are clear, engaging, and actually usable by the people they're intended for.
Okay, so we've designed this great program, pre-tested the materials, it looks good on paper, but how do we make sure it actually gets used effectively? That seems like a common failure point.
A huge failure point. And that's exactly what step 4. Specifying adoption and implementation plans is all about. This step focuses squarely on the diffusion process. How does the program get disseminated? How do organizations or individuals decide to adopt it? How is it implemented well? And how is it maintained over time? You can have the best program design in the world, but if no one picks it up or if they implement it poorly, it's useless. The insight here is you need to plan for this diffusion right from the start.
How do you plan for that early on?
A key task is developing a linkage system. Basically, involve the people who will eventually adopt and implement the program, clinic managers, teachers, community leaders, whoever, early in the planning process. Get them on the team or consult with them regularly. This builds ownership. They become partners, not just people you dump a program on later.
Like the CF example with the caregivers.
Exactly. Caregivers were on the planning team. And they also trained regional coordinators to be program champions. These champions then helped health centers adapt the program locally and create their own tailored implementation plans. It wasn't one-size-fits-all implementation. This step also involves spelling out what the implementers actually need to do. What skills do they need? What resources? How will they coordinate? It's about paving the way for the program to actually happen in the real world.
Okay, that makes a lot of sense. Planning for use, not just design.
hmm And what's really elegant about intervention mapping is how all this work feeds directly into the final step. Step 5, generating program evaluation plans. The products you created in the earlier steps, those detailed objectives, the determinants, the strategies, they aren't just for building the program, they become your tools for evaluating it.
Ah, so it sort of builds the evaluation framework as you go.
Precisely. Those matrices of proximal program objectives from step 1, they're basically blueprints for your measurement tools. The performance objectives tell you exactly what behaviors or environmental changes to measure. The determinants tell you which underlying factors, like self-efficacy or knowledge, you need to assess. And the specific change objectives can even give you content ideas for survey questions or observation checklists.
So it makes evaluation much more systematic and tied directly to the program's logic.
Absolutely. It really facilitates thoughtful, formative evaluation, too. That's the evaluation you do during the program rollout. Are people actually understanding the key messages? Are the activities engaging? Formative evaluation lets you check your assumptions and make adjustments along the way using real-time feedback. It also helps you set realistic timelines. Remember, the CF program expected health changes over 5–10 years, but the evaluation was planned for 2 years, focusing on more immediate behavioral and determinant changes.
Okay, so stepping back from the individual steps, what's the big picture takeaway here? What's the deeper value of using intervention mapping?
Well, I think its biggest value is offering this truly comprehensive approach. It connects the dots between needs assessment, program design, implementation, and evaluation, which was a real gap before. And it promotes what the source calls a problem-oriented use of theory. Meaning you start with a real-world problem, and you pull in whatever theories or evidence seem most relevant to understanding and addressing that problem. You're not locked into just one theoretical framework. You can draw from multiple perspectives, which is usually necessary for complex health issues. You fit the theory to the problem, not the other way around.
That sounds much more practical.
It is, and it's crucial to remember IM is not a rigid cookbook. It's designed to be iterative, interactive. It encourages participation from everyone involved, planners, designers, implementers, even community members. And decisions at one step might make you rethink an earlier step. That's expected. It helps ensure everyone is clear on what the program aims to do and how it's supposed to work.
And you mentioned earlier it also gives equal weight to behavioral and environmental factors, right? Which feels important for a holistic view of health.
Definitely. It forces you to think beyond just individual behavior change and consider the context, the policies, the social norms, the physical environment that enable or hinder health.
So how can this be useful for our listeners, maybe even if they aren't designing massive health programs?
Well, its principles are broadly applicable. It's obviously great for guiding evaluation studies.
Yeah.
It's fantastic for clarifying the why and how behind an intervention, especially if you're working in a multidisciplinary team where people have different backgrounds. And I really like thinking of it as a diagnostic tool. If a program isn't working as expected, your intervention map those matrices, the logic can help you pinpoint where things might have gone wrong. Just like using a roadmap helps you figure out where you took a wrong turn, the IM framework helps you troubleshoot and course correct your program. It's a powerful way to learn and improve.
What a fantastic framework. So to recap, intervention mapping gives you this systematic, evidence-based roadmap. It's for anyone really looking to build health education programs that have a real impact, ensuring those good intentions actually lead to effective action.
Yeah, what I find truly transformative is just its ability to demystify this really complex process. It makes program development feel more accessible, definitely more collaborative, and importantly, accountable. Accountable to theory, yes, but also to real-world data and outcomes.
So here's something for you, our listener, to mull over. Think about a complex problem or maybe a change you'd like to see happen. Could be in your community, your work, maybe even just in your own life. What if you approached it not just with a vague goal, but with a clear step-by-step map, identifying those specific objectives, really understanding the drivers underneath, planning exactly how you'll move forward, maybe even how you'll check in and adjust along the way? What would your intervention map look like, and how might thinking that way transform your whole approach?